You all for taking out the time to be here for this webinar. I am Dr. Dilpreet Bajwa. I'm currently working as a senior consultant at Artemis Hospital. And at this point, I would also take the opportunity to thank Mr. Varun and Jivo Healthcare to provide this platform. I think it is very important for doctors to connect with each other because there are a lot of things which a doctor can only tell a doctor and only doctors can understand. So, from that perspective, I think it's a great opportunity that Mr. Varun and Jivo have provided us. So, I thank you for that. So, without wasting more time, let me just begin with my presentation. I would like to share my presentation. Okay. Now, the reason why I chose this particular topic, cochlear implants and hearing loss, pediatric hearing loss is something it's very close to my heart. And, we are from a developing country. A lot of children have hearing loss in India. It is expected that out of every 1,000 children who are born, about 1 to 3 have hearing loss. And today I was just randomly searching and I figured out that there are about 60 to 65,000 children who are born in India every day. And if you are saying that even if one child out of 1,000 has hearing loss, that means we are looking at so many children being born every single day with hearing loss. And all these children, or majority of them, they go undiagnosed timely. And I'm pretty sure it would be a similar situation in Africa. Being a developing continent, there are a lot of reasons why hearing loss is prevalent there as well. And again, it gets unnoticed or undiagnosed timely. So, for me, my journey started with the cochlear implants roughly about more than 10 years back. And it's been a very fruitful and a very successful one. And I'm really thankful for all the families who have shown their belief in me. Okay, so quickly going through what I'm going to be talking about is a little basic thing I plan to start with. We start with what is sound, how do we measure sound, how do we measure hearing loss. Then we talk about what are the common reasons of hearing loss, what are the practical tests that can be done. If tests are not available, how can a family or a primary physician figure out if a child has hearing loss or not? Then we move forward towards cochlear implant candidacy. And cochlear implant alone cannot provide you good hearing. You have to have a very strong rehab team to support the program. Only then you will see the best outcome. Now, hearing is obviously one of a very important faculties that we are born with. Out of the 6 senses that we are born with, hearing is a very important one. And what is even more unfortunate is a child who cannot hear will not be able to talk, or a child who is not able to hear will have unclear speech. So, hearing loss is a silent disability. It is a disability which you cannot see, and hence this disability usually gets undetected till a long time, till the time is about 2 or 3 years of age. Sometimes even up to 5 years of age, parents don't realize that the child is not hearing. They just feel that the child is a late talker. He or she will eventually develop speech. Sometimes, when children have some moderate degree of hearing loss, they do develop speech, but it is not very clear. So the goal of implantation or the goal of treatment is not only to give them hearing. We want to give them good hearing. We want to give them adequate hearing so that they have a language outcome. They have good speech. They are able to socially interact. They are able to lead a regular, normal life as we would want them to have. Just a little bit about the anatomy, how we see the ear. The pinna is the outer part that we all can see. After the pinna, there is a 2.5 centimeter canal, which is called as the external auditory canal, which ends with the tympanic membrane. Behind the tympanic membrane are the auditory ossicles or the bones of hearing. The third bone or the stapes gets connected to the cochlea, the inner ear. And from the inner ear starts the nerve, which stimulates the brain eventually. Now, if there is any problem in the outer ear, for example, sometimes the pinna is malformed, sometimes there's a problem in the canal, there could be stenosis, there could be wax, there could be debris, or there could be a problem with the eardrum, there could be a perforation or infection. So all these are the reasons of conductive kind of a hearing loss that we see. And anything happening in the inner ear, in the cochlea, that causes the sensory neural kind of hearing loss. And this is just a small video showing how we normally hear. So it's when the sound waves, they hit the tympanic membrane vibrates, which causes the vibration of the bony ossicles. The vibration of the ossicles makes the fluid inside the cochlea to vibrate, which has frequency-specific hair cells. And these frequency-specific hair cells in turn stimulate the nerve, and that is how we hear. So just a very small, simple diagram showing how we hear routinely. Now, sound, of course, when I'm talking here, my voice is getting transmitted to you electronically. However, normally, if we are in the same room, how do you hear? How do you hear people around you? What is sound? It's very simple. It is just transmission of energy. My vocal cords are vibrating air at a particular frequency, and that energy is being transmitted from one air particle to another. And that vibration, it goes and hits the tympanic membrane, and that is how we hear, right? Now, sound has two very important qualities. One is called as the intensity, and the other one is frequency. Intensity defines how loud or how soft a person speaks. So the loudness is defined by the intensity, which we usually measure in decibels, and the quantity is defined by the frequency. So here is a very small audio kind of a thing, which is just okay. So that was just to show you difference between low frequency and high frequency. So the quality of sound is defined by the frequency, and the loudness determines the intensity, which is measured in decibels, and frequencies in hertz. Females typically tend to have a high frequency voice, and males tend to have a low frequency voice. But of course, it is a combination of all the frequencies together, right? Now, if we have to measure how much a person hears, we plot a graph where the decibels, the intensity is on one side and the frequency is on the other side. Because it's possible that I hear at 20 decibels at a certain frequency, but then I may not hear 2000 hertz at 20 decibels. So the hearing loss may not be same for everybody. This diagram is very, very important. The lightly shaded shape that you see in between, that is called as the speech banana. It is important to be noted that maximum sounds that we produce, they lie in the speech banana. So anybody who has a hearing loss about 40 decibels will probably miss on sounds like ch, sh, n. So these sounds will be missed by somebody who has a 40 decibels of hearing loss. And mind you, 40 decibels is not a lot of hearing loss. 40 decibels is what we normally converse in. And somebody with 60 decibels of hearing loss will probably miss entirely the entire conversation. So this over here is a chart which shows us the levels of hearing loss. So normal hearing is between 0 to 20 decibels. We say it's mild hearing loss if somebody can hear up to 40 decibels. Moderate is between 40 to 70. Severe is after 70 and profound is after 90. Now, when I'm talking, normal conversation is usually between 40 to 60 decibels. So somebody at mild hearing loss will have difficulty in normal talks as well. So that is a point to remember. And when I have to whisper, if I'm extremely small, extremely soft, I would be probably talking at about 30 decibels. And flights, aeroplanes, they go over the head, that is about 120 decibels. So just to get you an idea of what kind of intensity is. So normal conversation is about 40 decibels. As I was saying earlier, that hearing loss can happen if there is a problem with the pinna, if there is a problem with the cochlea. So depending on where the problem is, we classify hearing loss. Why is this important? Because conductive hearing loss at many times can be temporary because it is treatable. If there is wax in the ear, you just clear the wax debris. If there is fluid behind the eardrum, you give medications, antibiotics, the fluid dries up. But if it is a mixed kind of a hearing loss or a purely neural hearing loss, the chances are that medications are not going to help and the patient is going to be needing something more, maybe a hearing aid or a cochlear implant. Now, Hearing screening is routinely being done for all developed countries. However, unfortunately, in India, we are not screening every child for hearing loss. Most of the corporate hospitals have now started doing, but in the government setup, this is still lacking. And why hearing screening is important at birth is because if you miss a child who has hearing loss at the time of birth, there is a good chance that this child will be missed for the first 2 years of his life, and he or she will come back after the age of 2 years when the critical period for language development is almost over. So my recommendation would be that, if we are not able to screen every child, we should at least screen the high risk kids that we come across. High risk babies are the ones after birth who have to go to neonatal ICU, who had jaundice immediately after birth, had any meningitis or family history of CMV, or mother had CMV. So, any child who was born premature, had seizures, had ICU stay, had jaundice, or looks to be syndromic, appears to be syndromic, these are high risk babies. They should definitely be screened and appropriately handled. What is being followed in the developed countries is a rule of 136. Every child undergoes a screening test at the age of 1 month or before. If they are uh, supposed to have hearing loss, it has to be diagnosed by the age of 3 months, and an appropriate intervention has to be done by the age of 6 months. Intervention in terms of providing a hearing aid, or registering a child for rehabilitation, or just taking a note of the progress of the child if the child is getting developed with a hearing aid or the child requires a cochlear implant. So all that registry happens and the child is taken up. So this is not, of course, being followed everywhere. This would be in the ideal world scenario. However, the high risk children should definitely be screened. This is again just to show you that 136 rule is what we should be following. And the screening test that is done is called as the otoacoustic emissions. So otoacoustic emissions is a very simple test. It is non-invasive, it is painless, doesn't take much time. It just takes a few seconds, maximum 1 minute, and it has a portable it is a portable device, so it can be taken from one child to another. Parents need not visit you. Wherever the child or the mother is admitted, the device can be taken there and it can be done. Only once the OEE test shows that this child is probably suffering from hearing loss, then we might need to do the full test battery, which includes the BERA, the ASSRs, behavioral audiometry, visual response audiometries, and so forth. This is just to show you what an OE device is. It is very small, portable. The test is painless. It happens in a minute. So basically, we are looking at the health of the inner hair cells in the cochlea. So if the inner hair cells are working fine, they will emit back certain sound waves, which is picked up by this meter. So a healthy inner ear will reflect sound waves, and the presence of OAE means that this child probably does not have hearing loss. But if the otoacoustic emissions are absent, that means this child needs to be rechecked, or the child has any infection that needs to be looked at, and then OAE needs to be repeated. Okay, now if you don't have an OA machine, you do not have a BERA, you do not have an audiologist, what can you do? You need to know what are the language and hearing milestones we expect these children to develop. So a child between the age of birth to 3 months will have a general awareness of sound. For example, if you speak to the child will stop suckling. And if there's a loud sound, the child will have a startle reflex or a blink reflex. The eyes will open up wide. So you will see some subtle responses to sound in a child who's less than 3 months of age. A child between 3 to 6 months of age will look for the sound, where the sound is coming from. It will try to look, because it still doesn't have neck control, so it will not be able to move the head, but it will try to look with the eyes where the sound is coming from. The child will try to babble, sing, say mama mama, gaga gaga. So when a 6-month-old child says mama mama, it is not a meaningful sound. The child is not trying to call the mother. It's just a sound that the child is able to make, mama 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 mama. Between 6 to 9 months, child is able to respond to small words like no, bye, because those are the usual words that the children hear. So they are able to respond to those sounds. By the age of a year, a child should be able to respond to their names. So this is an important chart. I took it from the Indiana Department of Health, and I really think that every pediatrician, every general practitioner should have this in their room so that they can share this with the parents. Now, red flags. When should a parent or when should a doctor think that this particular child needs further testing? If not testing, maybe a referral to an ENT, maybe the ears need to be physically checked if there's any wax or any debris or any infection. So the red flags are there is no startle or blink to loud sounds at any age. Maybe a newborn child is not startling to loud sounds, that means something is wrong. If there is no babbling by 6 months, or the child is not saying even a single word by 12 months, that is a red flag. Does not turn to the name and heavily relies on visual cues. So many a times parents don't realize that the child has hearing loss, but what they say is the child only responds to them when they face the child. This because the child is looking at the parents' expressions, he's looking at their lip movement, and that's how the child is responding. So if the child is relying heavily on visual cues, there is a chance the child might have hearing loss. In older children, sometimes hearing loss may not present at birth. Sometimes it's a progressive kind of a hearing loss. Child was born with mild to moderate hearing loss, which progressed over a few years. So such children will definitely not be able to tell that they have hearing loss. Parents can perceive if the child appears to be inattentive in class or is repeatedly asking what. Okay, and the most important is when the caregiver themselves come to you and say that we feel our child has hearing loss, please test. When it is very, very rare for parents to come and say that we feel that the child has hearing loss, because maximum parents either don't know about it or they are in denial. So if a parent is coming to you and saying that, please don't tell them, oh, don't worry, the child is fine, he will speak at its own time. That's not going to happen. You have to refer these children for testing, if not testing, at least for an examination by an ENT. Now, this is just a battery of tests which can be done. So, starting from OE to BERAs, uh, those tests are being done everywhere. What is important is tests like visual reinforcement audiometry, conditioned play audiometry. These tests take time because the child has to be conditioned that they will hear a sound and then they have to appropriately place a block in a bin. So you have to condition the children doing this. The results of a conditioned audiometry or a visual response audiometry are way more precise than a BERA. But these are more time taking. Children have to come repeatedly. Sometimes, the families don't have the time, parents are working. So the quicker alternative is to do a BERA and SSR to see if the child has hearing loss or not. Okay, so just another chart to show that if you cannot look at every child, kindly screen the high risk babies, children who required NICU stay after birth, had birth asphyxia, had jaundice, any viral infection, meningitis, if there's a history of exposure to ototoxic drugs, or if a child, an older child, you see that there is a regression in speech. The child was earlier talking, now has become silent, is not able to you even say words that it was saying earlier. So if there is a regression of any sort, or you feel there is a failing of developmental milestones, the child is not achieving the milestones, the child looks syndromic. So these children need to be referred urgently. Now, what is to be done as an ENT? So if a child with probable hearing loss comes, of course, first, even by the moment the child walks in, by the physical appearance of child, sometimes you look at the face, this child has Downs. You are aware this child can have conductive component. He can have sensitively hearing loss. So many times the facial appearance of children gives us a clue. What is important is adenoid facies. Adenoids are a very, very common problem, and adenoids causes something called as middle ear effusion. So a lot of children come with this kind of a temporary hearing loss, which is secondary to middle ear effusion. You just treat the middle ear effusion and they are absolutely okay. If there is wax in the ear, there is debris in the ear, there is discharge in the ear, that has to be cleaned. The health of the tympanic membrane has to be ascertained, whether it is intact or not, and accordingly we treat. Now, since this is more about the sensorineural hearing loss, so I'm not talking much about what happens if there's a perforation or what happens if there is an effusion, because we will not have time for that. But what happens if, let's say, a child who's about 1 year of age comes to the clinic and the parents feel that the child is not talking age appropriately, you do hearing tests, you realize that the child has about 60 decibels of hearing loss. Now, in a child with 60 decibels of hearing loss at the age of 1 year, you it's a borderline case. This child may do very well with a hearing aid. This child may eventually land up with a cochlear implant if the hearing loss progresses, or if the child is not able to develop enough language. So, hearing aid versus cochlear implant is a decision that is based on a lot of factors and not only on the audiometry alone. So, usually in smaller children, like 3 months, 6 months, even if a child has profound hearing loss, the first thing is to fit them with hearing aids and see how much of development is happening with the help of hearing aids. In older children who are through 2 years, 3 years, we have less time because they are now moving out of that critical period. So we want to hurry up. We don't want to waste much of their time. So if we feel the child is borderline 70 decibels, 80 decibels of hearing loss, probably a cochlear implant is a better solution for them because hearing aid will only amplify sound. If you are giving a hearing aid to a person who has profound hearing loss, they may not develop adequate language because they are not hearing adequately well. Now, what is a cochlear implant? It is a surgically inserted device. It is reserved for people who have severe to profound hearing loss. Of course, there are exceptions. Sometimes, if somebody has a very sloping hearing loss, where the hearing is good in low frequencies, even then, there are like certain conditions where even in a moderate hearing loss, one might go for a cochlear implant. But when it comes to children, at least severe or profound hearing loss has to happen. Now, a cochlear implant is converting all sound signals into electric signals, and it is stimulating the nerve with that. So it tends to have two um, parts. One is the internal device, which is surgically placed, and one is the external component. Now, as you can see in this photograph, the electrode array is sitting inside the cochlea. That is what is inserted surgically. And the outer part, which has the transmitter and the microphone, it is worn on the outside behind the ear. Now, the sound waves are collected by the microphone and they are processed by the processor. And the transmitter helps to send these electronic waves to the receiver, which is on the inner side. And the receiver then sends these electric signals via the electrode array inside the cochlea. And these electronic signals from here, they stimulate the acoustic nerve. Okay, so that is just a little bit about how a cochlear implant works. Now, cochlear implant program or working with children who are implanted, or in fact working with children who have hearing loss, it is not like one person's job. It's a team. It's an entire team. You have to have an ENT on board. You have to have a pediatrician on board. You have to have a audiologist with you. You have to have a rehab person with you. Sometimes you also require psychologists with you. So it is an entire team which works together with the child and of course the parents to make sure that this child has adequate success in adequate time. So once a child comes to us with profound or severe hearing loss, if the child is small, let's say 6 months, we try to give a trial of hearing aids. If the child is above the age of 3 years, there is no point looking for whether the child is getting benefited with hearing aids or not. In a severe profound hearing loss, you straight away counsel the family for a cochlear implant. Of course, there are certain conditions where implantation cannot work. So we always do a CT scan and an MRI to see the anatomy of the inner ear as well as the cochlear nerve. And if the patient is found to be a candidate, we go ahead with a cochlear implant. Now, why are we talking that we want to do this early at the age of 1 year? Some people are doing it at the age of 9 months as well. So the reason why we want to do this early is because there is a concept of neuroplasticity. Now, what happens is that plasticity is the ability or quality of being easily shaped or molded. So I was just looking at, various definitions. So our brain has this beautiful quality called as neuroplasticity. So till the age of 5 years, it's actually maximum up to the age of 3 years. You bombard the brain with whatever information and the brain just grabs it and it changes accordingly. So a child who's born with hearing loss, if you're able to give them hearing by the age of 3 years, they will beautifully accept the implant. They will have beautiful language development and they will perform extremely well. You implant a child who's 5 years of age, they will also adapt to the implant. But the kind of sound or the speech that a 1-year-old or a 2-year-old will produce versus a kind of speech clarity a 5-year-old will have, they are different. So that's the reason why we know that the brain is very adaptive, is very acceptable to the changes, to the electronic signals when it is young. So that is why, that's the reason, everybody is nowadays saying that you implant the child as soon as possible so that the brain can develop as much as it can. Okay, so this is just to the current FDA guidelines say that implantation can happen only for a child above the age of 12 months, and the pure tone threshold levels, the decibels have to be profound. However, there are talks that the decibel values should be reduced to 70 decibels and not be 90. In older children, if somebody is using a hearing aid and if their speech recognition, if the words they are not able to recognize even 30% of a sentence, they are candidates for cochlear implants. So this is the current guidelines. However, they would be changed. They are on the way to be changed in the future. Just to quickly show you how an implant is done, we go behind the ear, we give an incision, we open up the mastoid bone, we form a mastoidectomy or a cavity there. And the blue triangle that you can see, that is the area where we open up and go into the inner ear. The round window membrane is the area where the electrode array is inserted inside, that's the implant. And in the round window membrane, we have inserted the electrode. And post-operatively on table, it is always advisable to take an X-ray to see that the implant is sitting well inside the cochlea. Okay, of course, it's a surgery. It will have its own risks, but it is a safe surgery, safe enough to be done for 1-year-old children. We do explain to the parents that there is a risk of facial nerve injury, there is a risk of CSF leak, but I would say it is a much, much safer surgery, so those things don't happen. One important thing is a risk of meningitis. Though no reports have been there so far all across the world, still vaccination is something that we do for meningococcal, pneumococcal, and Haemophilus influenza virus. Now, once the implant is done, you have to wait for about a week because after the implantation, there's something called a switch on. Switch on is the time when the external component is applied, and that's the time when a person starts to hear. But hearing does not mean that the brain is able to, listen everything. So hearing is just that the sound signals are going to the brain, but the brain needs to start understanding that every sound is different. Every sound has a different meaning. Verbal sounds are different. Somebody's talking to me, it's different. Non-verbal sounds like water, rain, waves, wind, those sounds are different. So depending on the age of implantation, this adaptation can take from 3 months to up to 6 months. However, after implantation, rehabilitation is an ongoing process and it requires about 2 to 3 years of rehabilitation for a child to be able to talk normally. And this part is usually taken care of by the audiologist and the therapist. They have to set the levels of the cochlear implant, a minimum threshold level and a maximum comfort level, and a lot of programming goes in this. Now, rehabilitation. Rehabilitation in case of children are taken care of by therapist, definitely yes, but parents as well. So it is a marriage between the therapist and the parents so that and the teachers, of course, at school, so that the children have the best outcome. So the device has to be used every day, every waking hour. The child is up, the implant has to be worn. There has to be structured listening goals. For example, the first day, the brain will only hear that, okay, there is a sensation, some sort of a sensation, then the brain realizes, oh, this is sound. So brain detects sound. Then there is discrimination, that every sound is different. If I say ah, this is different. If I say e, it's different. Gradually, brain starts to identify that ah is probably an apple and e is something different. And gradually the comprehension part comes. So a structured approach has to be taken. Parents and rehab specialists have to work together. And speech therapy versus auditory verbal therapy. Auditory verbal therapy is more of a parent coaching program. You teach parents how to take care of the therapy part, and this goes on even in the house. Okay, and the therapists, they have to obviously keep on monitoring the progress of the child. So parents have to work, of course, they are the first teachers of any child, so they have to work with the therapists together and provide good listening environment. If your child is cochlear, is using a cochlear implant, you're not talking to the child, you're busy with your work, you're busy on your phone, you're not talking to the child, that child is not going to develop speech. You have to take out time, talk to the child, read with the child, sing with the child. That's only when the children they start hearing and they start talking. And parents also have to be the troubleshooters, because it's an electronic device, so you need to know when troubleshooting is needed. So classroom success, of course, this comes a little bit later when the child is mainstreamed. There are a lot of technology available to keep these children um, at the forefront in classes. There are assistive technologies available. Teachers have to take care. They have to regularly, check in with the language. So peer buddy system can be developed, that you have a friend who's taking care of you. There have to be sessions taken by the rehab therapist with the school, with the family, so that the child does not feel isolated, or that that I'm the only one with the issue. So hearing loss in case of children, it's something the entire team has to work together. The parents, the rehab, the doctor, the pediatricians, everybody has to work together. And then is when you see the actual outcome. Okay, this is what I was seeing, that as per WHO, a regional office in Africa, that by 2030 we expect that hearing loss is going to be 54 million people will have hearing loss in the African continent. And the fact that many countries do not have ENTs, or have less number of ENTs, audiologists, and speech and language pathologists. Also, newborn screening is not happening routinely. So these gaps have to be filled. As a surgeon, as doctors, I think it is our duty to also try and talk to our governments, so that we have systems in line how to identify children with hearing loss. But after identification, we have to take care of their rehab as well, whether it be simple hearing aids or therapies, but we need to make those programs with the government. The good thing is that 60% of this childhood hearing loss is preventable. If we have vaccinations, if we had adequate access to antibiotics, there's a good chance that 60% of this hearing loss can actually be prevented, but it's a long way to go. So I shall finish off my presentation here, saying that in case of children, we need to act early because the brain is developing. We need to stimulate the brain while it is at its peak of development. Hearing aids, cochlear implants, both give access to sound. Of course, you require intensive rehabilitation, but these children are no less than the regular, routine, normal hearing children. If we provide them with the best of the facilities, they can do the best. Thank you.
Thank you, Dr. Dilpreet. So now we open the floor for the questions or any patient cases that our doctor partners may want to discuss. But I have a question. So like one cochlear implant is done, so in a child, so generally, when does the child need replacement for the implant? Like what is the life of the implant? Is it lifetime?
Yes, so
You
as
said
I
there's a
was
rehabilitation process about calibration and audiologists involved, but after that, does it need replacement at any stage? Does it have a shelf life?
So, as the cochlear implant has two parts, is an internal device and an external one. Usually, the internal device is meant to last the lifetime. It does not require any change. The outer devices are upgradable. They last for at least 5 to 7 years. And what we have seen is that every company in 5 to 7 years, they take out new technology. Like, for example, now AI would soon be introduced. So when new technology comes, people generally tend to upgrade. So the internal component, definitely the surgery is like a one-time thing. We don't want to repeat it until and unless, of course, somebody has a major accident, and that's another story. But usually they are safely built enough to last a lifetime.
Okay. So there's a question from Dr. Ivan. From Dr. Ivan is from Uganda. So can the implant be done for those who have hearing loss at a later age, like in adulthood? Is this a solution for them as well?
Yes, yes, and it's actually we are now implanting more of adults as well. So somebody who has had progressive hearing loss, they were born with okay hearing, but gradually they have lost hearing, they have developed language, they accept cochlear implants beautifully. So there is no contraindication for adult implant. Have they been hearing previously? Yeah, if you tell me that a person was born deaf, now they are 40 years of age, can you do a cochlear implant? Of course, we can do a cochlear implant, but the outcome in terms of whether such a person will be able to talk, hear meaningfully, is questionable. So, implanting a person who has never heard in his life after the age of 30 or 40 years doesn't, guarantee that outcome. But somebody who lost hearing later on, they are beautiful candidates for cochlear implants and they do extremely well. So, adults who are hearing aid users, but they are not getting adequate benefit from hearing aids, can definitely go in for a cochlear implant and they will love it, no doubt.
Okay, since Dr. Dilpreet, you mentioned this, I have a question because in your talk you mentioned the best age is as early as possible because of neuroplasticity of brain, which is best till the age of 3 or 5. So let's say we have let's this is a hypothetical case. So there's a child who was born with hearing disability, but is like 10 years of age, still in the school going age, and they can have they can have that rehabilitation procedure. uh, so are they candidates for cochlear implant? That is case number one. Case number two is somebody is adult, like 20s, not 40s, like 20s, early 20s or late teens. They are also hearing mobility hearing disability. And can they have, because now in all these cases 10 plus, 20 plus, the neuroplasticity window is gone. So how are these, I mean, how are these cases from perspective of realizing benefits?
Yes, so thank you. That's a very important question. See, what happens is that successful cochlear implantation, the definition changes with age. When a child, a 2-year-old child or a 3-year-old child comes to us, parents want that the child is able to talk. So for those parents, a successful outcome is that the child is able to hear and then the child is able to talk. That can happen till the age of 4.5, 5 years, no problem. But at the age of 10 years, 10 years is a very it's a dicey situation. Let me talk about the 20 years first. So when a child who has not heard for 20 years comes to us, of course, they come with the parents. Parents just want that the child is able to hear something because, they always feel that now we are getting old. This person has to look after themselves. We just want them to be aware of the sounds. For example, if they are walking on the road, and somebody is honking from behind and they don't even know about it. So at times, in a 20-year-old or a 30-year-old, the cochlear implant success is only sound awareness. Parents want that our child should be safe. If sudden noise happens, they at least come to know that there is some sound and they are able to take care of themselves. So the definition of success changes. At 20, I would not expect a 20-year-old to be able to talk, but the brain will be at least able to understand loud sounds. If adequate rehabilitation is given, probably such a person will be able to understand what the parents are saying. He may not be able to develop adequate language. 10-year-old child is somewhere in between. This child may go on to develop a good language. This child may not develop language at all. So, that's why we have to counsel the parents that the successful outcome we are talking about changes with age. Are you talking only about hearing? You want that your child should be able to hear? Fine. You implant a 20-year-old, he will be able to hear. But if your goal is that he's able to talk as well, that may not happen. So if for the speech to develop, the brain has to be pliable enough. So that happens best if the child is less than 3 years of age. Another case scenario would be a 10-year-old child who lost hearing probably after an infection, or a 20-year-old man who lost hearing after an infection. Such people, since they have been hearing throughout their life, you do a cochlear implant, they hear very well. But if they have been deprived of or audition lifelong, then yes, the sound awareness will come, but not enough for them to be able to talk.
So, ma'am, the ability to discern like language or spoken word, or even to ability to learn speech, so the reason for them not being candidate for this at a later age is neuroplasticity, the brain function that you talked about, right? Or is it that Language cannot be developed at a later age if somebody has not developed early.
Yeah, I think it's because of neuroplasticity, language will not develop. They will definitely benefit from an implant. They will be able to hear. But if you're talking about communication, that is something they will probably lack. Or even if they're able to communicate, the language may not be very clear. Like they will not be able to talk like you and I. Otherwise, there is no contraindication. There is no reason why a 40-year-old cannot get an implant. They can definitely get an implant, but we need to set their expectations that this person is going to be requiring a good amount of rehabilitation, and still their language may not be as good as a regular 40-year-old.
Okay. Now we have a question from Dr. Moira Martin. Apart from children, what are the treatment options for adults who develop hearing problems later in life with no prior medical conditions?
Okay. So, presbycusis, adult on age-related hearing loss is a common cause. People of the age of 80, 85 years old, if they develop presbycusis, which is severe enough to be not treated with hearing aids. So first option is always a hearing aid. If hearing aid is able to give you adequate hearing, by adequate hearing, I mean meaningful hearing, that you're able to discriminate between different words. If the hearing aid gives you adequate, meaningful hearing, you just use hearing aids. But if the hearing aids are not able to give you meaningful hearing, the clarity is not there, all you hear is noise, you can undergo a cochlear implantation at any age. So a person who has no prior medical history of any sort probably has developed sensory neural hearing loss, because otherwise there would be some history. For example, people who have perforation will have some ear discharge. Otosclerosis also starts early in life. So if there is no prior history, chances are that this is the sensory neural kind of a hearing loss, which can be treated either with a hearing aid, but if the hearing aid is not providing adequate accessible sound, then definitely a cochlear implant can be done.
Okay. Now we have a question from Dr. Gozi Ogu. Will it be used for adults with hearing loss due to cancer, such as chronic myeloid leukemia? Some of
Yes, why not?
develop
Absolutely.
tinnitus and sudden hearing loss, especially when the
Yes.
white cell count is very high, example above 300.
Okay. So, definitely CML patients, even CKD patients, so chronic kidney disease, any chronic condition. So, because CML is a very indolent kind of a disease, it does not cause issues like any acute leukemia. So, if somebody has CML and hearing loss, they can definitely go for a cochlear implantation. The life will be much better because they will be able to talk, socially interact. And anybody who has a chronic infection can undergo cochlear implantation. Of course, we vaccinate such people before. We will not go in for a cochlear implantation without vaccination.
Okay. So, Dr. Dilpreet, now we come to question. Let's say what you mentioned about cochlear implant is it's not one-time surgery. There is a lot of follow-up and rehabilitation, which requires medical skill plus therapist skill, and again those enabling factors like parents and right conducive school environment and teachers. So now let's say somebody from an African country comes, a child comes, gets the cochlear implant done. So now the link, this long process cannot continue in India. When they
Yes.
go back, so how is it addressed if there's a lack of professionals, who can adjust or calibrate that external use, that they are required. So how is that handled? How is that part handled?
Yes, so fortunately now programming is available online, because these days almost all devices, they have Bluetooth capacity. So like we are talking right now on Zoom, exactly same manner, with the help of the app they can connect via the laptop or phone. The audiologist, the rehab specialist has the same app on their system. You just connect via the app, like AB has AB remote. You connect via AB remote, they are able to wirelessly program it. You don't need to come here.
Okay. And another aspect is, ma'am, for anything, affordability is also a practical aspect of this world. So now this cochlear implant, which is definitely, a very critical solution in hearing challenged kids. But then how affordable it is? Can families afford this
Unfortunately, even for
implantation?
Indian parents, for Indian families, cochlear implant is not covered by insurance, and the device is pretty expensive. So we do have funds for Indian families, because there are the CSR funds which are available. There are different programs which are run by the country, by the government. So we are able to cater to our Indian population with the help of those funds. Unfortunately, we do not have anything available right now for catering to the international population.
No,
But
but let's say if somebody pays out of pocket, then how
yeah.
much does it cost to the parents? This implantation surgery and device and everything.
Okay, so see, there are three major companies which produce cochlear implants, and they have they have different models. So we always discuss with the family. We tell them that this is the device, these are the devices, and these are the pros and cons of having this particular device or that particular device. So we let the parents decide on which cochlear implant would suit their pocket, because any implant you choose, I mean, the implants have been there for the last 40 years, and every device has been used by a generation of people. And we have not seen anybody not doing well. So the implants work, even if you take a device which is not very expensive, even if you take an expensive device, they work. So what makes the devices, different in terms of costing is, one is the MRI capability. The device, the external and the internal devices, they have to communicate. So there is a magnet, because otherwise nothing will stick on my head. So there's a magnet on the inner side of the internal implant, and also on the external. So the more expensive ones, they have 3 Tesla compatible magnets. The less expensive ones, they have only 1.5 Tesla compatible. So MRI compatibility guides the cost of the device. Secondly, their programming. The devices which cost less, they don't have those auto programs. Right now we are on the Zoom call. I go out, there would be some noise. I go out on the road, there would be like traffic and horns and all that noise. So my brain is adapting to changing environment. But a child or an adult who is using a cochlear implant, the implant has to adapt to changing listening environment. So the devices which are not very costly, this constant sorry, change will not happen. But the expensive devices, they have this inbuilt feature wherein the device is scanning the environment every 3 seconds. So in a silent environment to a noisy environment, it will change the program on its own. Third is the Bluetooth capacity. The latest devices now have inbuilt Bluetooth. You have a phone, you have a pad, you have a computer. It will connect automatically if the Bluetooth is on. So that makes life very easy. So these are a few things which define whether the implant is going to be, not expensive or extremely expensive. If I give you a rough estimate, I would say that surgery, including the device, starts from about 14,000 US dollars for 1 year. It goes up to $36,000 for, if we're talking about the high-end implants.
Okay. Okay, ma'am. That helps. So it's a very wide range and
It is a wide range, yes, yes. And I always say, whatever the parents decide, it's the best for their child. So they don't have to worry that I'm not able to afford an expensive device. What's going to happen? Nothing happens. They all do very well. Also, the external component is upgradable. So that anyways will require to be upgraded in 7 years. Right now, if you feel that I am going for a basic device, it's fine, because you will anyways upgrade it later on. And smaller children, they do not require very high sophisticated devices anyways. So, because it's a small child, it will adapt. Only once a child enters the school going age, you want all those things that, Bluetooth should be there. The child should be able to talk on the phone. And so those features are basically needed by bigger children.
okay. So, ma'am, you mentioned a very interesting point. So, the component that is implanted inside the brain, that's for lifetime, and the external device gets upgraded. And we
Yes.
see today in today's world, the change in technologies faster.
Yes.
As we move ahead, the changing technology is faster. So with the so basically the cost, what you're talking about is at least the upgradation in the external device. The child, let's say if 10 years they change in technology, the child may benefit further from that, right? Is that what you're saying? Or would
Yes.
that device implanted inside, would that be a limiting factor?
See, fortunately, the companies who are producing implants, they are very cognizant of the fact that as the technology changes, the compatibility might change. So already the inside devices, they are upgradable. So they have put in the technology inside. Already the technology is like so advanced that you can upgrade and nothing will happen. So the first person who was implanted in 1984, it's like 42 years from now, that person is still using the internal device. Of course, he has upgraded the external device, but the internal is still the same. So the cochlear companies, they are, at least keeping that thing. They understand that as the technology goes, compatibility loss should not happen. So that so far they have been very, good about it, and the external and internal devices have been compatible. So that man is using that 40-year-old internal device. Of course, the upper one has been upgraded, but it is compatible.
Okay. Thank you, ma'am. Let's wait for 1 or 2 minutes. I think we are almost reaching the end time of the masterclass also. Uh, if anybody has any more questions to ask, please ask. And otherwise, if you, any question around cochlear implants or hearing loss solutions from ENT perspective, otherwise as well, if you have any questions that come up, or if you have a patient whose case you want to discuss, please write to us on your work group or reach out to your relationship manager, and we will direct that to Dr. Dilpreet. And okay, we have no more questions. So, Dr. Dilpreet, thanks a lot for your time. And I think we can conclude the session with your permission. And I want to thank everybody who joined today. Like, doctors work all whole week, and Sunday is the family time, and that too, Jivo Jivo takes up your time. And but these dialogues are very important because that builds the dialogue between practitioners on both sides of the border, the India-Africa axis. That builds a confidence in the medical community. It helps us learn from each other, and then whenever there is a relevant patient, provides the best counseling and guidance in what is best for them. So thanks, Dr. Dilpreet. Thanks a lot for your time, taking
Thank
time out
you.
on a
Thank you. I
Sunday.
also thank everybody. Thank you so much for taking out time to be present here. Thank you, Mr. Varun. Please feel
Thank you,
free to
ma'am.
contact Jivo. Thank you,
Thank
Dr.
you.
Varun. Thank you. So please feel free to contact Jivo team, and I would be happy to help anytime you have any questions about hearing loss or even otherwise about ENT. If there's any issue, I would be happy to help. Thank you.
We always do that.
Thank you, everybody. So now I'm concluding the session. Thanks a lot.
Thank you.